Good evening, dear colleagues. I'm Dr. Cosmin Dima from Romania, and my topic for today is aesthetics around implants. And I'm going to talk first of all about one new technique, which is called snake technique, and after that I'll share with you a very difficult case from the frontal area. But let's start with the lateral area. And I don't tell you aesthetic zone and non-aesthetic zone. Many years ago I started to think that lateral area is the same aesthetics like the frontal area. And the concept of the snake technique is based on the idea that the lateral zone is just as important as the aesthetic zone. I'm sure that many of you have cases like this with a concave area between the implants, and this concave area could provoke food retention and peri-implantitis in the future. And of course, we have some options to treat this kind of situations. One option would be the pink porcelain, but I'm not sure this is the best idea. Another one could be bone augmentation, and again I'm not sure that in this case bone augmentation could help us. But another one is soft tissue augmentation. And looking at all three options, I'm sure that soft tissue augmentation is the best decision in this case. Let's see what kind of soft tissue augmentation we can proceed. We can do connective tissue graft, we can use a free gingival graft, but what about a pediculated graft? And the difference between the first one, which is dead because we interrupt the vascularity, the second one is dead, but what about the third one? The third one is alive, because keeping it pediculated, we have 100% of the time vascularity in the graft. And of course, this is very important for our future result. Another idea when I said this concept was the idea of one wound concept. If I would be the patient, I would like to have only one surgery, as less as possible, as less invasive, and of course, only one wound. I didn't find any patient until now, and I'm sure you didn't too, any patient who asked me to take a free gingival graft from the palate if this is not necessary. But for having this technique clear, we have to define some ideas. And we have, first of all, to set the flap edges, and then to deepithelize the graft, like you can see in the picture. We have to prepare a split thickness, like we can see in the picture, and we need a thickness of 2 millimeters, at least 2 millimeters, and then we can roll it and proceed like you'll see in the next slide. We need also to keep in place at least 1 millimeter of keratinized gingiva to have a very good healing after the surgery. And then after we prepare the partial thickness flap, we can roll it and we can try in if it's long enough and if it fits perfectly. In this particular case, I decided to use also the tunneling technique to increase the papilla volume. And this technique was described by Anton Sculean, and it's very important when you detach the papilla to keep in mind that you have to detach no more than 2/3 of the papilla at the base, and 1/3 at the top must be in place to keep the vascularity and to be attentive not to fracture the papilla, like you can see in this picture. After that, seeing this picture, I have to give this technique a name because I have searched the literature and I didn't see anybody else proceeding with this technique. So the name was snake because seeing this picture in my mind, it looked like this. And that's why I gave the name snake. After rolling the graft between the two margins, I have fixed the mesial part with a PTFE suture, and then we just roll the graft and suture it to compress it and to eliminate any dead space. Because one of the keys in succeeding in grafting is to have no dead space between the graft and the receptor site. And we are helped by this technique to eliminate easier this dead space, like you can see in this picture immediately post-OP. You can see after 10 days post-OP that the healing on both sides, donor and receptor, is excellent. You can see increasing the volume, and you can see before snake and 10 days OP that is a big difference. And now we are ready for the final restoration. And we see that we started with a concavity, and now we have already a papilla between the crowns. So snake works, but the technique works if it lasts for many years. And we can see that after 1 year the tissue looks even better, and after 2 years it looks even better. Because we obtain here we transform the concavity in a convexity, which is very important, and we obtain keratinized, thick, attached soft tissue, which is the golden standard. And it's very important to transform the concavity into convexity, because concavity leads to two big disadvantages. The first one is food retention, which can provoke in the future peri-implantitis, and the second one is a gray shadow, because heavy concavity leads to a gray shadow, which is not aesthetics. Of course, in this area, maybe for patient is not so important, but for me is important. The same patient, but this time on the lower jaw on the right side, a little bit more complicated. We can see that we start with this area, which is very thin, and we have to prepare a very good treatment plan. And I recommend you to take time for preparing the treatment plan, because sometimes preparing the treatment plan is even more important than the execution. Why? Because if we think at the treatment plan wrong, for sure we will end up with a mistake. That's why it's very important to define the technique, and in this case we can do it with single approach. We have to define from the beginning the crestal or other kind of incision, this time crestal incision, and I have decided to use the periosteal pocket flap, and I will detail it. I decide also to use the resorbable membrane with autologous bone, and every time I use PTFE sutures. So the first step is the incision. After making the incision, we have to reevaluate to see the thickness of the gingiva, to see the thickness of the bone, and to decide if our treatment plan is correct. And in this case, for sure, the treatment plan is correct. We have exactly the same situation like we had it on the CBCT. So we decide to use, like I told you, the periosteal pocket flap described by Marius Steinman and Maurice Salama in 2014, which starts with a crestal incision, preparing a full flap until the mucogingival margin, and then we prepare a split flap. And you can see here in the picture the periosteum, very nice. The big advantage is that when we use this kind of detaching instruments, we don't cut the vascularity. So we don't have bleeding, too much bleeding, and the patient will be more comfortable after the surgery. No swelling, no pain, comparing to this kind of section with the scalpel, which interrupt the vascularity and for sure for the patient is worse after the surgery. After detaching after the mucosal detachment, we can see that we have increased more than enough the elasticity of the tissue, so now we can graft the area, graft the bone as much as we want, and we can close after that without any tension, because it's very important to have a free tension flap. And you can see now that we will have a free tension flap at the end, no matter how much substitute we will use for bone grafting. In this particular case, I have used the same idea of one wound, and I decided to harvest a bone block with piezo and to use it in the area where the bone was very thin. Why did I decide to use the piezo? Because we have some advantages, like you can see here. We are minimally invasive, which is very good for both practitioner and the patient, and for sure we have a minimal bone loss, which is also very, very important. After harvesting the bone block, like you can see here in one wound, we just put it in place. So we took it from this area and just put it in this area. Just have a try in before. You can see that the margins are different. I just cut a thicker one where the bone defect is bigger and a thinner one to the back, to the distal, when we have more bone. And then we just started to prepare some corticotomy for bleeding and insert the implants, and you can notice the bone defect around the implants. So now it's time to fix the bone block. Usually I use 2 screws to fix the block to be very stable, but in this particular case the block was very stable after using only 1 screw. I was prepared to use 2, like you can see I have 2 holes, but having the block so stable I just decided to use only 1. And then to fill the gap between the bone block and the receptor site with the same autologous bone, took from the same area with a bone scraper. And after that, on top of it, I have used some xenograft to have the area more stable. And of course, I have covered it with a slow resorbable membrane. Like you can see in this picture, I have used even 2. One from the periosteum from inside at the bottom, and the second one only on the crestal to have more protection on the crestal area. And after that we have to stabilize it with sutures and then to close the flap. And as I told you, it's very important that we don't have any tension in the flap. Like you can see here, we can close it perfectly without any tension. But one of the problems when we use the bone grafting and we detach the mucosa is that we move the mobile tissue on the crest. And after we have the bone augmentation, we need to go to prosthetics. And we know that it's very important to have around our crowns, around prosthetics, thick keratinized attached tissue. And in this case, we don't have it, so we have to improve also the soft tissue. So now snakes worse again. We just start with deepitalization and we increase the volume on the buccal side. This time different technique. We just roll it on the buccal side like you will see in the next picture. You see we can increase the volume and then we just make the suture. And we can see that we have started like this. We close it with a continuous matrix suture, and only 10 days post-OP the healing on both sides, donor and receptor, is very good. And I insist also on receptor side healing because it's very important to have a very good and fast healing for the patient. Of course, if the healing is faster, the patient is better. And after that, we can notice that we moved the mucogingival margin to the buccal exactly as we want. After that, of course, we need the prosthetics, and as I told you, we need keratinized tissue around the crowns, and you can see it immediately after cementation. So snake works. But look, after 1 year, it looks even better. And after 2 years, it looks much better because we have gained here keratinized, thick, attached soft tissue, which is the golden standard in the modern implantology. And a good technique is a technique which works not only in 1 or 2 cases, but in many, many cases, like you can see in the pictures. And I assure you that every case works perfectly with this technique. Let's start with the advantages, because if we use a technique, we have to have any advantages, otherwise there is no reason to use it. And do we have any advantages to use the snake technique instead of the classical techniques like free gingival grafts or connective tissue grafts? Yes, we have. We have the graft stability, because having one part very stable, being attached, pediculated, we just have to fix the other part and the graft is very stable. We have only one wound, which is very important for the patient. Of course, sometimes we like surgeries and we like to cut more, but for sure, if we would be the patients, we would like to have only one wound. We have a better vascularization, and maybe this is the reason that leads to very good results, and I don't have any problems with this technique about the necrosis of the graft. And of course, we can avoid the dead space under the graft because we can compress it better. And of course, we can see that it works in time, and I show you 1 year, 2 years, and for sure in time it will be better and better. And we want to end up with this kind of results. And every time I start the cases, I think to myself that I have to end up with this kind of results. But sometimes it's not so easy. And let's see the frontal area with a very difficult case where it's not so easy to end up with such kind of results. The patient is very young. She had an accident at 14 years old, a bike accident, and she had avulsion of tooth 1-1 and a fracture on the tooth 2-1. The problem is that she was wearing a Kamini removable prosthesis for 4 years. She came to me when she was 18 years old, and between 14 years old and 18 years old she was wearing a removable prosthesis. So she was very sad. She was comparing herself with her grandmother, putting the Kamini in the glass of water, and of course this comparison was very dramatic to her. So now you can see it. Sorry, I understood that it was a technical problem. I can see the slide, but I understood you couldn't. Maybe because the case is so dramatic that she didn't want to appear here. So coming back about this young and nice lady, she had that accident, and having a closer look, we can notice that there are so many problems. So it's very difficult to promise her that we will have a perfect result in this kind of case. And we can see the bone defect. We can see a very bad angulation of the tooth 2-1, which looks like being out of the bone and pushing the gingiva. And we know that we can never achieve this kind of convexity with bone augmentation, and we can never place the implant in such a position. And we can see even worse having the CBCT, like we can see it here. So we have to start from a ridge with about 2-3 millimeters. And of course that in this case we have to keep in mind the 7 rules of aesthetic implant dentistry. And the first one is that we have to have the buccal plate at least 2 millimeters, the soft tissue around 1.5-2 millimeters, interproximal height of the bone class 1, high crest of the bone at the adjacent teeth, correct implant position from the prosthetic point of view, which is very important. Of course, the flap is very important, the flap design, and the emergence profile also very important. But let's see how it looks like on our patient. The buccal plate is less than 2 millimeters, the soft tissue is so poor, the frenulum is in the middle of tooth 1-1, which you'll see is not so easy to correct. The tooth 2-1 is in significant buccal angulation, a big problem for the final aesthetics. And she has also gummy smile to be at worst as possible. The main concern of the patient was wearing that camini. So first of all, we have to focus on the main concern, and in this case I just put away the camini and prepare a Maryland bridge for her because she likes to have a fixed prosthesis. She doesn't want to wear any removable prosthesis. And now we can see the Maryland in position, and we can notice even better the bone defect and the poor soft tissue. So it's time to start the treatment plan. In this case, for sure, we cannot do it in only single approach. I like to have only one approach and to solve every problems of the patient in only one session, but in this case I think it was impossible. So we have chosen the stage approach. The incision was crestal. The flap design was full thickness, but also the split flap, like you'll see in the next slides. I have used a resorbable membrane. I have used also autologous combined with xenograft for bone augmentation, and every time I use PTFE suture. So having a case like this, we have to go to the basics and literature and to think very well what option is the best for the patient, but also what option is the best in our hands. Because as we all know, the best technique is that one that works in our hands. And in this particular case, for sure, some of us would choose to augment, to graft the bone with only autologous bone. Another doctors would go for autologous plus xenograft, and so many options. But as I told you, I think it's very important to take this option which works in our hands, but also having based in literature. And before incision, I think we have to keep in mind three very important criteria. The gingival biotype. You will find in my presentation many times slides about the gingival biotype, which is very important when we start the surgeries for healing and for the final result. The interproximal height of the bone is very important when we decide to make the flap, because if we cut the papilla in a interproximal height of the bone class 3, we damage it forever, and the buccal bone of the adjacent teeth the same. If we insert the blade inside the sulcus and we have the buccal bone class 3, we will provoke recession, and the patient would come with one problem and go home with 3 problems, which of course is very bad. In this case, I decided to use the technique described by Istvan Urban because I know it's a predictive treatment, it works in my hands. We can use the resorbable membrane, which is more comfortable than the non-resorbable membranes, and I can use a combined autologous bone mixed with xenograft. And I like this kind of approach because I know that the xenograft gives us more stability in time, and I don't want to be too invasive for my patient to graft only autologous bone. And I know that this is success treatment. So now, having all in mind, we have to define the past principle, actually not to define, just to remember the past principle described by Homley Wang in 2006, which talks about the primal wound coverage, angiogenesis, pace maintenance, and stability. All these 4 criteria are very important. If we lose only one, we can lose the case. So don't forget to keep in mind this principle, which in my mind is very important for any surgery we start. Now it's time for incision, because we have the treatment plan, we have the knowledge, we decided the techniques, it's time to cut. But before cutting, we have to check these 5 points. 1 and 2 is about the interproximal height of the bone, and after making the anesthesia, I check with the probe if this is the same like on the CBCT to be sure that I have class 1. So only in this case I cut the papilla. After that I check the buccal bone of the adjacent teeth. And then number 5 is also very important to have the measurement of the height of the keratinized tissue on the crest. This is a very important criteria to know how deep we can insert our implant, because now we can insert the implant crestally or subcrestally. But how subcrestally? 1 millimeter, 2 millimeters, or many more millimeters. And there are so many options and ideas in the literature. But I think that the most important thing is to think biological. And we know that biological width is present in every case. So we have to keep in mind the remodulation considering the biological width. And I recommend you to take in consideration also the zero bone loss concept described by Thomas Linkevicius. And you will see and decide easier how deep you can insert the implant, or if you need to insert it subcrestally, because sometimes we don't need it. It depends on the thickness of the gingiva and of course of the quality of the gingiva. After incision we can raise a full flap, and we discover that the bone defect is really big, so we have only 1.92 millimeters like we saw it on the CBCT cross section. And then I recommend you to prepare the flap, to mobilize the flap before starting the bone augmentation, as I told you. Because if you prepare everything, you put the membrane in place. After that, you put the bone grafting in place, and you notice that the flap doesn't work, so you cannot cover everything without any tension. Everything is ruined. You have to start again. You have to cut the periosteum with all the augmentation materials in position, which is not so good because you can insert the granules inside the tissue, and for sure it will be worse for the patient, and hematomas and swelling and pain will occur. In this particular case, we have one more bad thing like this frenulum, and I decided to make the frenuloplasty in the same session because otherwise I have tension in the flap. Even if I prepare the flap properly, the frenulum would have tractions on the flap. Then I decided to harvest the bone from the nasal spine on the same concept, one wound concept. Why should I cut another area? Why should I make another anesthesia on the lower jaw and to prepare another wound when I have bone enough in this area? And of course, we prepare the cortical plate with some spots to have a better vascularization, some perforations, and after that we just put the membrane in place and we are ready to graft the area. And I have used the combination of the autologous and xenograft 50-50% like in Istvan Urban's technique. After that we just cover everything with a collagen membrane, put the suture in place to stabilize it, and then close it properly, and you can see now the convexity, transform the concavity into convexity, and you can see also the frenuloplasty with the frenulum mobilization, not have any tension in the flap. What I recommend you also is when you make the vertical incisions, be very attentive and try to make the vertical incisions in the concavities, not on the convexities, because sometimes we can have scars, and we know that cutting vertical, the fixed keratinized tissue leads to scars, and cutting horizontal, the mobile tissue will have scars too. That's why we can notice after 10-20 years after apectomy scars which are forever. So don't forget to make these vertical incisions in the concavities like you can see here. And like you can see, I'll go back a little bit. I make a 90 degrees angulation, which helps me to put the graft, to put the flap in place better. And you'll see that at the beginning we have some small scars, but after that the remodelation is perfect without making any entry over there. So we started with a concavity, with a big concavity, bigger than it looks in this picture, and now we have convexities on the buccal and on the palatal area too. So on the CBCT we started with 2.63 millimeters, like you can see here, the bone defect, and end up with 9 millimeters, 3 times more. But this is not enough. It's important how much will regenerate and how much of this bone augmentation material will be bone, real bone, patient's bone. And we can see after 6 months that the healing is very good. The gingiva looks good but not perfect. And it's time now for insert the implant. And for inserting the implant, of course, we have to plan it very well. An implant planning must keep some ideas in our mind. We have to insert the implant in the cingulum position. We have to insert it according to biological width. We have to keep the space 1.5 millimeters more than 1.5 millimeters to adjacent teeth. And the angulation is very, very important and will have to be around 70 degrees. Of course, we have a lot of aspects which leads to implant success. You can see in the center the biotype. You can see also in the center the implant positioning, which are very, very important, but also the bone quantity and quality and the periodontal aspects, the emergence profile, the occlusal situation, and everything you can see here, I think is very important. And you can see also the bibliography. These are not my ideas. This is science, not what I tell you, but science. I would recommend you to avoid a second incision in the sulcus, because if we have many incisions in the same area, after the second, the third incision, you will see that the tissue are moving and moving in a bad way. So if it's possible, it's better to avoid the incision in the sulcus and cutting the papilla again. So I did this flap without cutting the papilla, and then just preparing the osteotomy in the perfect position from the prosthetic point of view, so cingulum position. You can see now the amount of bone grafted is not perfect. Remodelation was not perfect, but not so bad, because now we can insert the implant. We have bone enough to insert the implant, but we don't have bone enough for a very stable result in time. That's why in the same time with the implant insertion, I decided to have one more grafting, bone grafting. And the implant is very important too. In this case, I have chosen a V3 MIS implant, because I like very much the idea, the concept of having on the neck of the implant a straight line instead of curved line. And the difference between the straight line and curved line is occupied by the bone and not by the titanium. So we have more bone where it matters the most. I check every time when I'm doing the osteotomy, but also after inserting the implant, because if you are working with very aggressive implants, you can change the angulation by pressing the implant. So I check every time at every step to be sure that at the end my implant will be in the ideal position. And you can see now that the implant is in the ideal position, so in cingulum position, and of course the angulation is good. It's not like the 2-1 tooth, which was very, very angulated to the buccal. We have the implant inside the envelope of the bone, so we know now that this kind of augmentation is predictable. First of all, we put the membrane in place. This time I have used a slow resorbable membrane like O6 Plus. I prepare the bone grafting, and after that I have covered the bone grafting with this membrane. I double it on the crest, and this is another important idea, I think. I didn't want to mobilize the tissue from the buccal to the crest to take the soft tissue which is mobile near the crest. So I decided that if I have such a thickness on the palatal soft tissue, let's split the soft tissue on the palatal and put one more coverage on the crest, having more tissue, and at the end keeping in mind that we can modulate it, remodulate it by pressing the crown and to have a better gingival contour. Like you can see here, so a split flap on the palatal, and then just making a horizontal matrix suture, put it on the crest and close it without any tension and perfectly. So I have tried to increase also the soft tissue volume, which is not enough. And we know that we can gain bone, but we cannot gain it convex. We cannot go outside of the envelope. And you can see now how much volume we have gained on the buccal area. And you can see after the heating that everything looks good, but it doesn't look perfect. You can see now that the implant is surrounded by a lot of bone, but it's not bone. It's not bone at this moment. It's only augmentation material and bone. So we need in time to have bone, real bone. And we started like this, and after bone augmentation and implant insertion, you can see it how big is the difference. You can notice here that the implants looks like being too close to the lateral, but I assure you that it's not like this. You can saw it the osteotomy, it was perfectly centered. And after the healing, it looks like this. We can notice that we have bone, but we can notice also that we don't have enough emergence profile on the buccal area. And the only way to increase the buccal volume and the profile on the buccal area is with soft tissue. We cannot graft it anymore with the bone in that area. That's why I decided to use a free gingival graft. Unfortunately, we cannot make a snake here. It would be great, but we cannot do it. So I have decided to use a free gingival graft from the palatal area, like you can see here. We don't need more than 2 millimeters. We have to deepitalize it. And of course, we have some advantages. We prevent recessions. We change the biotype and increase the biotype, which is very important for the long-term result and long-term stability. And the graft has to look like this to be very dense, no fat. When you see that is yellow, you know that is fat. And if you know that it's fat, you know that it will resorb. So be attentive to have a very dense and white graft like you can see in this picture. Then I prepare a tunnel. I made a split flap. I didn't raise a full flap to interrupt my bone grafting remodelation, just a split flap, and then insert the graft in this tunnel. And you can see that we need only 2 points of fixing the graft and then put the provisional in place. If you work properly and if you don't go too deep, you don't need here any material and any sutures. I see very often sutures here, but I don't know why, because if you don't go too deep, you don't have too much bleeding. Actually, we don't have bleeding here, like you can see. So I don't put anything here. because in my opinion, if I put something here, I just make the healing longer, and I just make nervous the patient putting the tongue and feeling the sutures every minute. I keep the line, the gingival contour, a little bit lower than the adjacent tooth because I like to have the possibility to push the gingiva and to reshape the contour with the final crown. And now, after having the gingival contour better, it's time for prosthetics. We decided to make a crown on the tooth 212 because the angulation was bad, the position was bad, the tooth was fractured, so there was no reason to keep it like this. And after that, it's very, very important to work with prosthetics properly. One important thing is the emergence profile, and you can see the difference between the left and the right side. We have to allow the soft tissue to grow, to have the thickness, to have a very stable result in time. Otherwise, if I prepare it convex and we push it, we have resorption, and the gingival contour will be higher and higher. So don't push the gingiva too much, just allow space to have enough thickness to have a stable result in time. Another very important criteria is the contact point, and you can see here the measurements for the contact points between the contact point and the bone crest. If we have 4 or 5 millimeters, we have in 98 or 100% papillas. But if we have more than 6 millimeters between the contact point and the bone, it's decreasing dramatically from 49% to 2%. So keep in mind also this, and ask your technician if he or she doesn't know this, to prepare it like you know is better. And now it's time to reshape the gingival contour. We have the 2 crowns in place, like you can see here. Maybe it's not perfect, but for our patient is more than perfect. Now it's easier for her to smile. She was like having a photo shooting. She was very happy. She was very cooperative because at the beginning she didn't want to smile. I need more than 15 minutes to make her to smile to catch a picture. Now she was smiling and smiling. And we can see that after 1.5 years, the bone remodelation is perfect. We have bone enough around the implant. We have bone where it mattered the most on the neck of the implant. And for sure, we have a stable result in time, which is very important. We can see also on the vertical that the bone is stable. After 1.5 years, the gingival contour is stable too. And again, maybe it's not perfect for us, but for the patient it's quite perfect. And now she can smile, look at her face, look at her teeth, and look at her eyes, because they say that the eyes are the mirror of the soul. And when I have cases like this, I like to have a picture with the patient's eyes. And that picture reminds me of the first session when she was crying and she had tears on her face because she was so upset. And now she has tears of happiness on her face. Saying all of this, I just want to thank you very much. Thank you, MIS and Dental Tribune, for making this possible. And I just want to ask your questions. Thank you very much. Have a nice evening, and I wish you many, many happy patients. So, let's see the questions. I hope I will answer to all of you. Do you recommend removable interim prosthesis during the healing period of the implant? No, I don't recommend removable prosthesis. I try to avoid them, and I know this is the worst thing we can do, to put a removable prosthesis on the implants and to give shocks on the soft tissue, on the hard tissue. If we have bone regeneration and soft tissue regeneration, for sure we have to avoid them 100%. And sometimes we can we have to tell to the patient that they are supposed to wear nothing for a few months. Very, very rare. I like to have my patient with teeth provisionals every second, but sometimes in very difficult cases, and I'm talking about the full arch, when we don't have the option to place some provisional implants to stabilize fixed prosthesis. No, I don't go for removable prosthesis. Sometimes I find that the occlusion does not allow the Maryland as a provisional. Yes, you are right. Sometimes the occlusion is not favorable for this kind of bridges, but I think we can do it. Even if we can glue it between the teeth and put a very, very thin layer and uh, fix it as much as possible, but avoid the removable prosthesis. I think we can find an option to fix it and to get rid of the removable prosthesis. Thanks so much, and so many nice words. Thank you very much. Very nice words. What is the good text and resource for learning about the snake technique and other soft tissue grafting? Please write me a message, a private message, and I will give you many more informations. And I think if you were here, you can see the lecture again and again and to see the details about the snake technique. But if you need some more details, we just can connect in private. You had my email address and my Facebook, like Dr. Dima Cosmin, and just write me a message and I will tell you as much as possible. Excellent lecture. Thank you very much. Could you briefly explain soft tissue molding using provisionals? Oh, I can explain, but I need 1 more hour. So to be short, the most important thing is not to press the tissue too much, because if you press it too much, you can provoke necrosis and you can push it too much, so you will end up with a gingival contour higher than you need. But of course, you have to keep in mind the other teeth, the adjacent teeth, and to modulate the crown so that you allow the tissue to grow, but to push it a little bit, because if you just make the concavity too much and you don't push the tissue a little bit, you don't have that convex gingival contour. You'll have it a little bit concave. And if you have the contour concave, that leads to a gray shadow. And it looks very good when we make pictures or when we put our light from our office. But after the patient stand up and goes to the mirror, she maybe said, oh, doctor, but why so gray here? And if the patient tells you that is gray, when you have the final crown in position, it's too late. So be attentive to modulate it from the beginning. Sorry, I cannot give you all the details because, as I told you, I need 1 hour. Go snake, thank you very much. Do you prefer to modify the temporary crowns clinically, or do you modify the test by altering the cast? Yes, a very good question. Sometimes I prefer to altering the cast, and I try to copy exactly the DSN tooth. And this works most of the time, but you have to keep in mind the biotype and the amount of tissues you have there, because sometimes you can do it only by altering the cast and by pressing the tissue, but sometimes not. So I think there is no general rule. I think you have to define every case and to treat it like a singular case, and to decide knowing the literature, knowing your skills, knowing your technician skills, and after that to put all together for the best results. Otherwise, if you feel that you cannot obtain the best result, just send the patient to another doctor, because I think the most important thing is to have the patient happy and treat it like you would be the patient or your girl or your family, and you'll change a little bit some ideas. What's the tool that you are using for snake technique? For snake technique, I didn't use a special tool. Maybe you saw a special tool, but I use it when I used it on the periosteal pocket flap. That one is mucosal detachment described by Marius Steinman, and it's called TK Steig, and it's specially designed to detach the mucosa from the periosteum. Doesn't cut so strong like a scalpel, so it's much better to use it. Pick abutments and zirconia crowns as opposed to titanium and other crown materials. Yes, there are so many discussions about abutments, and as I told you, I have a very good opinion about the zero boneless concept described by Thomas Vinkevicius, and he showed that the best material tolerated under the gingiva is the zirconium polished manually without any glaze. So I think this is the best option to have in contact with the gingiva, zirconium polished, manual polished without any glaze, and after that the glaze crowns, zirconia or AMX or another kind of crowns. Volumax collagen membrane. Yes, Volumax collagen membrane is the same family with O6 Plus. I use also Volumax membranes. Sometimes it helps, sometimes not, because if I want to have more grafting material for the bone, I prefer to use O6 Plus because the membrane is thinner. But if I don't need too much material for grafting the bone, then I can use the Volumax. For sure, I like to have more bone augmentation than the augmentation with collagen membrane, but it works very good. And I can tell you that I uncover some membranes like O6 Plus and Volumax after 9-12 months, and they are really hard. I don't know if it's bone. I don't think it's bone like they say, but it's really hard and keeps the augmentation material in place, and I think this is the most important thing. It doesn't matter if they are transforming into bone or something else, but if they are a space maintainer, a very good space maintainer, I think this is the most important thing. Can you use Mucoderm? Actually, I think the best option is with our materials, with natural pre-gingival graft or connective tissue graft. I checked the literature and I saw different opinions. Some of them said that the mucograft works. Some of them said that they don't have stable results in time. I don't want to say something because I didn't use too much. I just tried at the beginning and then I switched to natural tissues like the snake technique or the classical free gingival grafts and connective tissue grafts. The inflammation after the grafting with your Maryland. No, there was no inflammation about the Maryland. It was the healing process. So everything went perfectly. I didn't have any inflammation about the Maryland or any opening of the flap. It was quite perfectly. Can you write his name? I think I don't see the entire text. That's why I don't understand a few messages. What is your opinion about the temporary abutment for aesthetic case? Yes, you can use, of course, you can use temporary abutment for aesthetic case, but I told you, I'm going for this idea of Thomas Dinkevicius having the zirconium abutments manually polished under the gingiva. In order to secure your membranes. Yes, very good question. How do I secure my membranes? Because unfortunately, at this case, I didn't have pictures, but I secure the membrane with sutures. I don't use resorbable sutures because when they are resorbing, they are generating an acid around my grafting, and I don't need this. So I use the same PTFE sutures. I start from the buccal side and then cross the membrane, enter to the periosteum, and come back to the buccal. So I can fix the membrane very good, and I just let in place the sutures for 3-4 weeks, and then remove it, just cutting on the palatal, only one cut, and then I can pull it out. You are the best, simply the best. Thank you very much. Okay, thank you very much. And if you have some more questions and you want to know some more about the snake technique or the other parts I have told you today, just write me private messages and I will answer you. Thank you very much.